Today we shall be looking at fluoroquinolones. To start with a little history, in the year 1962, nalidixic acid was discovered by George Lesher during the synthesis of chloroquine, and it was given a name quinolone. Fluoroquinolones were later derived by adding a fluorine atom into the nalidixic acid structure, and the earlier quinolones were useful only for the treatment of urinary tract infections, and the fluorinated derivatives achieve a higher bactericidal levels in blood and tissues so that they have an improved antibacterial spectrum against a variety of gram-positive and gram-negative bacteria. The most commonly prescribed fluoroquinolones include norfloxacin, ciprofloxacin, ofloxacin, levofloxacin, acloxoxacin, and pefloxacin. Quinolones work by blocking bacterial DNA synthesis by inhibiting the bacterial topoimerase II enzyme known as DNA gyrase, and as well as the topoimerase IV enzyme. The inhibition of the topoimerase II, which is a DNA gyrase, prevents the relaxation of positively supercoiled DNA that is required for the normal transcription and replication of the DNA, which is used during bacterial multiplication. The inhibition of topoimerase IV enzyme interferes with the separation of this replicated chromosomal DNA into their respective daughter cells during cell division. When looking at the antibacterial activity of fluoroquinolones, the earlier quinolones such as nalidixic acid did not achieve systemic antibacterial levels, were very useful in the treatment of lower urinary tract infections. Their fluorinated derivatives have a greatly improved antibacterial activity compared to earlier quinolones. The excellent activity of the fluorinated derivatives against gram-negative aerobic bacteria has a limitation in their activity against gram-positive organisms. This relative activity against gram-negative versus gram-positive is so useful for the classification of these agents into various classes. The fluoroquinolones are classified into 4 generations: the first generation, second generation, third and fourth generation. In the first generation, we have nalidixic acid, cyanoxacin, oxolinic acid, and pimecidic acid. These ones were known to have a gram-negative activity, but they were not effective in Pseudomonas species infections. On the addition of the fluorinated atom or the fluorine atom into their structure, they developed the second generation fluoroquinolones. The second generation fluoroquinolones include norfloxacin, levofloxacin, sparfloxacin, enoxacin, ofloxacin, lomefloxacin. This second generation are active against gram-negative Pseudomonas, gram-negative infections, as well as Pseudomonas, and some gram-positive activity against Staphylococcus aureus and atypical Mycobacterium. Then in the third generation, we have levofloxacin, gemifloxacin, sparfloxacin, temafloxacin, and moxifloxacin. This generation of fluoroquinolones have the same activity as the second generation. However, they have broad extended activity against gram-positive and atypical mycobacterials. And lastly, we have the fourth generation fluoroquinolones, and the most common example is trovafloxacin. Looking at the specific examples and important knowledge that we need to understand in the fluoroquinolones, norfloxacin is the least active drug against both gram-negative and gram-positive microorganisms. Ciprofloxacin enoxacin, lomefloxacin, ofloxacin, levofloxacin, and pifloxacin, possess excellent gram-negative activity, and they have a moderate to good activity against gram-positive bacteria. And looking at the streptococci and enterococci, these two bacteria tend to be less susceptible than staphylococci against the fluoroquinolones. Ciprofloxacin is the most active agent against gram-negative microorganisms when comparing to other fluoroquinolones. Levofloxacin, which is an L-type isomer of ofloxacin, is known to have a superior activity against gram-positive microorganisms, for example, Streptococcus pneumonia. Gatifloxacin, gemifloxacin, and moxifloxacin make up the third group of fluoroquinolones, which have an improved activity against gram-positive microorganisms and some staphylococci. In general, none of these agents is as active as ciprofloxacin against gram-negative microorganisms. Fluoroquinolones are known to have an activity against agents of atypical pneumonia, for example, mycoplasma and chlamydia, and as well as they have a coverage against intracellular pathogens such as Legionella and Mycobacteria. Moxifloxacin, on the other hand, has a modest activity against anaerobic bacteria, and due to the toxicity of gatifloxacin, this drug was recalled from the market. The resistance to fluoroquinolones is due to one or more point mutations in the quinolone binding region of the target enzyme, or it occurs due to a change in the permeability of the microorganism. Resistance to one fluoroquinolone, particularly if it is a high-level fluoroquinolone, confers cross-resistance to all other members of the fluoroquinolones class. Pharmacokinetics of the fluoroquinolones. Fluoroquinolones are known to have good bioavailability when taken orally, and they are usually distributed widely into body tissues and body fluids. They have a serum half-life ranging between 3 to 10 hours, and oral absorption is normally impaired by the presence of divalent and trivalent cations, for example, the cations that are found in antacid medications. Oral fluoroquinolones should be taken 2 hours before or 4 hours after any product that contains these divalent or trivalent cations. Fluoroquinolones are eliminated by renal mechanism through either tubular secretion or glomerular filtration. In patients with a creatinine clearance of less than 50 milliliters per minute, there is a need for dose adjustment. Fluoroquinolones have a limited CSF penetration, and their distribution is higher than in serum concentration in tissues, for example, the prostate tissue, the bile, the lungs, kidneys. We basically use fluoroquinolones in the treatment of urinary tract infections, bacterial diarrhea, soft tissue, bones and joint infections, as well as intra-abdominal and respiratory tract infections. Ciprofloxacin is a drug of choice for the treatment and prophylaxis against anthrax. It is effective in the treatment of chlamydia urethritis or cervicitis, and ciprofloxacin, levofloxacin, and moxifloxacin are occasionally used in the treatment of tuberculosis and atypical mycobacterial infections. We can as well use the fluoroquinolones in the treatment of invasive external otitis, salmonella type infections, gonorrhea, prostatitis, and cervicitis. Some of the adverse drug reactions that we realize whenever you're using these fluoroquinolones are nausea, vomiting, and diarrhea. However, most fluoroquinolones are well tolerated when taken orally. Some patients will have central nervous system effects, for example, headache, dizziness, insomnia, skin rash, or abnormal liver function tests, and some have as well reported photosensitivity. Fluoroquinolones are known to cause QT interval prolongation, and gatifloxacin has been associated with the development of hyperglycemia in patients with diabetes and who are on treatment with oral hypoglycemic agents. Fluoroquinolones are known to cause damage to growing cartilages and causing arthropathies. These arthropathies are reversible. Tendonitis, which is a rare but potentially more serious complication, can occur and leading to a risk of a tendon rupture. When looking at the drug interactions, these fluoroquinolones antibiotics are enzyme inhibitors. Therefore, they inhibit the cytochrome P450 enzyme, interacting with other drugs at the metabolism point, for example, theophylline, warfarin, and caffeine. Non-steroidal anti-inflammatory drugs and quinolones are known to cause and increase the risk of convulsions. These NSAIDs as well are known to potentiate these effects. Fluoroquinolones, like we said before, are contraindicated in children, pregnant mothers, mothers who are lactating, and patients with a history of epilepsy and a QT interval prolongation. These